morning, everyone. I am Naomi, I'm one of the PY4s, and for this year, we're starting the social ethics and palliative EM lectures. We're just trying to build into our curriculum more social determinants of health and how can that affect our population, so we get better and more proficient and more culturally sensitive in our care in the emergency department. I'm going to be talking about end-of-life care in the emergency department.
Okay, click on yours.
What?
Click on your side.
What? Here? Okay. So the objectives of this lecture, we're going to be talking about some legal documents. It's a little bit dense and boring, but stuff that you need to know. How to document end-of-life conversations. And we're going to go a little bit over withdrawal of life-sustaining interventions in the ER. Disclaimer, I'm not a lawyer. I'm not palliative care trained, so I'm sorry if what I'm saying is wrong, because it's all what I found on my research, and this is not to steer any controversy. I know that what I'll be talking about in the last slides, it's a little bit intense. The point is not to offend anyone. Obviously, if you don't believe in withdrawal care, you don't have to participate in it, okay? Why this matters? So research shows that this improves quality of life because patient is receiving care in order with the goals of what they would have wanted, and this tends to be less resource intensive. Not everyone's goal is to prolong their life. Some people prefer more of a quality of life than a quantity of life. Some people like a happy medium, and because medicine is not paternalistic anymore, meeting the patient's wishes and expectations within the realms of medical feasibility is what we should be doing in our practice, okay? The overview of how it should go. Goals of care discussion is a fluid process. It's an ongoing conversation. So first you have the family conversation, you fill the forms, and then you write the orders. Just so you know, this is something that you have to reassess in every hospital visit and every time that they're seeing the doctor, because this is a fluid thing and the wishes of the patient change depending on their current medical status and what they believe it's right to be done during those circumstances. So just make sure that you reassess every time this patient comes to the ER. Oh, you were DNR before, do you still want this? And that's an important conversation to have, not just assume that this is what they still want, okay? So the first step, you have to revise if there are any prior forms. Review what is on the form, and like I said before, last time you said you wanted X, Y, and Z. Do you still feel this way? Is this still what you want? And then you also have to confirm the healthcare proxy, which is the person that will make the decisions in case they are not able to do so. And if there are no prior forms, this would be a good time to start advanced care planning process. I think all of us as ER doctors feel very uncomfortable when we get an elderly patient with no care plan in place, and then you end up intubating them, doing CPR, and you're like, well, I don't know if this would have wanted, but I also don't feel comfortable not doing anything, and like, am I doing what's right? So having a good care plan in place can actually stop us from doing this. And it also decreases admissions, it also decreases healthcare costs, and you're also abiding by what the patient wants. So doing this conversation early on is better than not having it at all, okay? So the step 2 would be to complete the form. This is actually very important. This study showed that adults over the age of 60 that died between 2000 and 2006, 42% required decision-making about treatment on their final days. And inside this 42%, 70.2% actually were deemed to lack decision-making capacity. So that is about 29% of people during their end of life need a surrogate decision-making or cannot make their own decisions. So having someone appointed early on with decisions about what you want, or just having written down what you would have wanted, is very important. And now we're going to talk a little bit about the forms. This part is a little bit dense, and I apologize for that. First of all, we have advanced healthcare directives. So this form legally names your healthcare proxy. The healthcare proxy is also known as your durable power of attorney for healthcare, medical power of attorney. It has many names, but it's basically you're appointing someone legally that is going to make your decisions only if you're deemed incapable to make your decisions. So they can only make decisions if your doctors say that you're not capable of doing so. In this advanced healthcare directives, you can also add an instructional directive or a living will. In this part, you are adding what you would like to be done onto your body in very specific scenarios. So you're allowed to add would not like hemodialysis, would not like blood transfusions. And you can actually be as specific as you want and add as many scenarios as you want. You as a young person can have an advanced healthcare directive, and you can write also from when would you like that to start and when would you like that to end, or if it's an ongoing process. The problem is, if you don't know about medicine, this document can be somewhat vague. So people don't know when this in what scenario this would become active. But you can basically just say what you would have want done to your body, or if you die, what would happen. This is how a advanced directive form looks like. The first part, you name the healthcare proxy. So you're saying, I, Naomi Rebollo, appoint so-and-so to make the decisions if I am unable to do so. I am only unable to do so if my doctor decides that I don't have the competence to do so. And this patient will have the authority to make the decision so-and-so per my wishes. Here in this part, you can add as many pages as you want. This is where you put all the scenarios that what you would have wanted for your body, depending on, the circumstances. On this part, you choose if you like life-sustaining interventions or no life-sustaining interventions. So it can be as specific as you want, and the only issue with this part is that you don't know when this comes into effect. Like, let's say you have pneumonia and then you have respiratory failure and you have chosen before to prolong life, and you have chosen before to not prolong life, but then this is actually something that's reversible and you never wrote if that was the case that you would like treatment for that, then EMS doesn't know if that's valid now or valid under a different condition. So for EMS, this document is not useful. This document is useful for in-hospital doctors. This part is the relief from pain. Is like if they would accept pain medications, even if they can hasten death. And then any other wishes that you would like there. This is for organ donation. This part is optional. And the last part is where you sign it. You have a witness sign it. And for it to get validity, it should be notarized by a lawyer. We also have the most post forms. There are many variants of it, and the names change state by state. But basically, it stands for physician orders for life-sustaining treatment, medical orders for life-sustaining treatment. This is actually only for seriously ill patients that have chronic conditions and are known to likely die in the next year or so. You can choose very specific treatment preferences. The only issue with this one is it doesn't legally appoint a healthcare proxy. So the living will and the other advanced directive is better for legally appointing a person. This one is better for legally appointing what would you like to be done during end of life. But this is only valid for seriously ill patients, like I mentioned. We could not get this form done, okay? And then EMTs can actually use this because this form, it's a traveling form basically, and so if you have it available and the EMS can access it, they are supposed to honor your wishes. So if they decide bring to hospital but not CPR, that's what they should do. This is how a most score look like. This is the most score for New York. So it's usually pink, and the reason for that is because you're supposed to put it on the physical chart, and it's easier to find. But now you can just find it in the internet and just fill it on the internet, and it'll come out with an electronic most number. And so that way EMS can also access it if you don't have it readily available. So the DNR, the most one has many sections inside it. The first section talks about CPR versus no CPR. And this is basically pretty straightforward. You go down here and you decide if you want cardiopulmonary resuscitation or if you don't want cardiopulmonary resuscitation. The second section is basically where you sign that you consent for whatever you decide on the section. Do you want CPR or do you don't want CPR? And then the doctor is supposed to sign it here. For New York, physician NP should sign this. This is not true for every state, so you should read the guidelines wherever you guys end up practicing. But if it's not signed by a doctor in New York, then it gives it no validity. Further sections for it, it's a bit more specific for when the person has a pulse and it is breathing, but why would you like to be done in that case? So no limitations would be the full blood work sticks, antibiotics, all this stuff. Limited is you can get medication by mouth through a vein and heart monitoring, but nothing too extra. And then comfort measures only would be just oxygen pain medication. During the same section, you can choose if you want a do not intubate, if you want prolonged intubation, or if you like a trial period. You can do a trial period of non-invasive intubation, you can do a trial period of intubation. If in 2 weeks this doesn't work, then I just want it out. And all of these things you can specify later. You can also choose if you would like to be sent to the hospital in the future, or if you would like to be taken care of at home and just pass comfortably at home. This part talks about artificial feeding, IV fluids, and all that stuff. If you like that versus not like that, if you want antibiotics, limited trial of antibiotics, or just nothing at all. And then in this part, this says other instructions. You can decide, and that one you would have to list if you want dialysis, blood transfusions, any other procedure that you would be okay having. And then this part is the same. It needs to be signed by you, witness, and your provider for it to be valid. The last part of this form is just for every time they come to the hospital, you're supposed to review it. So here you put the date of admission, who's reviewing it, and if there's any change in the patient's wishes or status. Now we're going to talk about how to write medical orders in your chart. I know that many times in CCT we sign out and we're like, oh, this patient's DNR. Okay, cool. But what do we do with that? So we have to be more specific. DNR, DNI doesn't mean the patient can go to the ICU. DNR, DNI just means no intubation, no CPR, but it can mean maybe BiPAP, maybe dialysis. So it depends. And so in your chart, you have to be very specific when you write that. Patient would not like intubation or cardiopulmonary resuscitation, but he's okay with blood draws, he's okay with antibiotics, he's okay with a trial of non-invasive ventilation. If he needs blood, he would like to receive it. And so we cannot limit our care based on a DNR, DNI. We still have to do what's right by the patient. So we need to be very specific when we document the goals of care conversation and what the patient wants if we're having these conversations in the ER. And then documenting in your note, it's important to write who was present, when this was done, review, if any, prior documentations, write the name and number of who's the proxy or surrogate to be making the decisions, And then you have to talk about the goals. Like, would you want this to be done on your body, or would you prefer to extend your life, but you would be inside the hospital, hooked to all these machines, to all these tests being done, what treatment preference you would like, and that you would go into code status, artificial nutrition, trial of intubation, and stuff like that. One of the most important parts, and I think that we don't address this part in the ER a lot, it's leeway. Are these orders very strict, or do they shift ever so slightly depending on your medical condition? What about if you were comfort care, but you happen to have a UTI? Like, can you receive treatment for that and make your actual life more comfortable? So the leeway is very important to document as to if the patient is comfortable us going an extra mile just during that particular occasion. For EMS protocols, like I mentioned before, the traditional living will is not helpful for the EMS people because there are multiple restrictions that state when it should take effect. So usually not very useful for EMS, but useful for the doctors to use as a guideline for making decisions. The physician orders for last-extending treatment, which is our MOLS form, it clearly expresses the wishes of the physician and all EMS. If they're able to say, yes, I have a MOLS form and this is what I want, and present it to him, they should go by it. This is not always the case. The surrogate's not always present. These forms cannot be made that fast, and so sometimes EMS doesn't do what the patient wants, unfortunately, just because of the not obtaining the forms in a timely fashion. So we're going to talk a little bit of a case now. So we have a notification for respiratory failure. We get an 89-year-old male with lung CA, 3 years home to hypertension, diabetes, multiple admissions for hypoxic respiratory failure. He was intubated by EMS en route. While you're doing some chart review, you know that he had a prior MOLS form, and it said next time DNR, DNI. And then now the healthcare proxy comes to the ER and is able to produce the form and shows you this. Patient would not like to be intubated. So what do you do now? So now we're going to talk a little bit about withdrawing life-sustaining interventions in the ER. It is our duty as physicians to preserve life and relieve suffering, and I feel like sometimes these two come into conflict. So preserving life and relieving suffering, or prolonging life and continue suffering. So it's kind of a fine balance. Life-sustaining treatment can prolong life without reversing the underlying disease process, and this does not necessarily improve quality of life. The problem is that withholding and withdrawing medically and legally are okay. The problem is for us as humans, one of it is a passive action versus an active action. Withdrawing actively care feels very much more uncomfortable for us as doctors than withholding. We're like, oh, this patient is coding, we're just not going to go the extra mile because we know that the outcome for this patient is going to be very poor, as opposed to everything is already done, I'm going to stop it and take it out. And that feels uncomfortable to us as humans. And one other thing, so I want you to understand that withholding is the same as withdrawing illegally, even though there are different forms, one is active and one is passive. Also want you to understand that allowing death is not the same as killing. Again, medical and legally, this is okay. These are legally distinct, and this goes with the ethical principles of autonomy and non-maleficence. It's better to not do something than to do something and risk more harm. And then one of the other things you have to understand for withdrawing life-sustaining interventions is the double effect of doctrine. There were multiple cases, landmark cases in the past of withdrawal intervention that ended up in court. And after those cases, they decided on the double effect doctrine that it was okay. So basically what this means is if I'm giving you pain medications to alleviate your suffering, but this at the same time can hasten your death, this is acceptable because I am not giving it to you to cause death. I'm just giving it to you so you can die in a peaceful manner. And so if you guys understand these three differences and how they come into play into end of life, I think you guys will feel more comfortable with the topic. This study, I know that it's done in the ICU. I couldn't actually find any studies of withdrawal carrying the ED, and it's because we don't do it. But it talked about the predictors of time to death after withdrawal of mechanical ventilation. And so this study showed that the median survival of time from withdrawal was 55 minutes. So when you take, you extubate terminally someone, you can expect them to be alive 55 or so minutes to about an hour. And this is approximately 93% will die within 24 hours. There are some outliers, so these other 6.8%, some of them might survive a week, months. There's no way of telling. Unfortunately, you have to be comfortable with that uncertainty. But most of them, approximately 93, will die within 24 hours, and the big majority within 1 hour. So what medications can we use if we're withdrawing mechanical ventilation in the ER? So we can use opioid drips, and we are going to target to comfort, and that means facial grimacing, grunting, and target to a comfortable respiratory rate, usually less than 30. We can also add benzodiazepine pushes with the opioid drip to titrate to this comfort as well. Very important that if the patient was intubated and on paralytics, you should stop it at least 30 to 45 minutes before. And the reason behind this not to be cruel is just because it can mask signs of discomfort on you. And so you're not doing right by the patient in terms of the opiate and the benzos, because you wouldn't be able to tell if it's uncomfortable or not. And then these are the actual medications that you can use. I want to actually take your attention to the adjuvants over here. This scopolamine patch is a antimuscarinic, so it helps with nausea and it decreases oral secretions. And this is a patch, but this, to work, it has to be given 30 minutes before starting the procedure. Glycopyrrolate and atropine can be given PO, sub-Q, IV, and also be given about 1 hour before starting the procedure. And then you can continue giving them and titrating to oral secretions. You start with a morphine drip. You can start at 0.5 to 2 milligram IV bolus, and then you continue in a 0.5 to 3 milligram infusion, so basically a morphine drip, and you can keep up titrating, like I said, to patient comfort. You can also use drip of hydromorphone and fentanyl. I think fentanyl is one of the easiest ones for us to get in the ER, so I would recommend that one. And the dose for that one is 0.7 to 10 mcgs per kilo per hour. And then it's very important for your anxiolysis, and here is where you're titrating to patient comfort. You can use lorazepam and midazolam. Very important to have extra. So you start doing 2 milligram pushes, but just order more because and have it at bedside, just because you don't know when you're gonna have to give it, and just to make sure that your patient is comfortable throughout this very difficult process. There's 2 ways that you can go about this. you can do immediate extubation versus terminal weaning. So on immediate extubation, you gave all the meds that we talked about. You rapidly remove the ET tube, you suctioning, you clean the patient, and then you put them on a humidified air or some sort of oxygen tent. And then you just continue giving medications and titrate for comfort and clear their secretions. You can also do terminal weaning. Terminal weaning takes a little bit more time, so if you're doing this in the ER, just make sure that you have the staff and the time to do so. Basically, you give all the medications we also talked about, and you start decreasing your settings in the vent. First, you go to your FiO2, and you decrease it to 0.21, this is room air. And you start titrating to respiratory rate your medications. You decrease your respiratory rate, you start decreasing your PEEP, and keep up titrating medications to comfort. And then once you're at minimal settings in your tube, you can just take it out. In theory, you're supposed to start decreasing your mechanical ventilation settings every 15 minutes or so. And if the patient survived this, then you remove the ET tube and you just give some sort of oxygen tent, nasal cannula, and it's just for comfort. And that's basically how you would go about it. Some considerations though, when you're doing this, is beware of your environment. Try to turn off all alarms that can make the situation more uncomfortable. Remove any restraints, any activants like oral tubes or anything for feeding. You turn off all the blood pressure cuffs. Everything else that you don't need, you take out. Like I said, stop press or support in paralytics, FiO2 to 21%, suction oral secretions, and the most important thing is you have to have this conversation with the family before starting, if they want to be there or if they would not like to be present. Just let them know that it's kind of a hard process to see, and most people will actually decide to be there with the patient, and just talk to them about expectations. You know how I told you that some survive up to an hour or some about 24 hours. So they have to understand that the passing is not immediate and that can take up about 1 day. But like we said, we're going to make the patient as most comfortable as possible. And a lot of families actually decide to be in the procedure. And just these are the references I used if anyone has any questions.
Naomi, I thought that was very great, and the point you made about withdrawing and withholding in that slide, and some people on Zoom also really like that. Yeah.
Just a comment. I think it's incumbent of us to be on the lookout for patients that are potentially need those care discussions. Obviously, cancer is the one that comes up a lot, but just remember CHF, COPD. You could also progressive terminal diseases. So the patient's being admitted to the hospital more frequently. They're needing more advanced care. They're failing home care. These are the times when you start talking to family and patients about what they would want, even if you're not predicting that they're going to get intubated or need CPR. But start these thought processes. And they may even be considered for hospice. You kind of don't realize that CHF and COPD patients are terminal and progressive disease.
Yeah, and it's always good to get help. If you're not sure, get a palliative consult, especially in patients who are going to die within 6 months. You predict in New York State, 6 months to a year, you probably are supposed to get a palliative consult. And they can decide on hospice. And I've actually gone through this lately.
Very good, man.